Good afternoon, everyone. I'm Rick Lifton, president of the Rockefeller University, and I'm delighted to welcome all of you to another of our sessions, virtual discussions with genuine experts. This is the sixth in a series of webinars that Rockefeller launched in April to discuss the COVID-19 pandemic and the vital work on COVID-19 being undertaken by scientists in 25 Rockefeller laboratories. To date, we've covered topics including the use of antibodies in fighting COVID-19, the role that human genes play in the progression of the disease, the race to develop new drugs, and the potential of convalescent plasma in treating the virus. This week's session is going to be a little different. I'm thrilled to say this afternoon we are joined by the 9-time Emmy Award-winning journalist Paula Zahn, who will be interviewing me in a broad discussion of the SARS-CoV-2 virus and the COVID-19 pandemic. Paula is a legend in television news. After a distinguished career in local news in major cities across the country, Paula was introduced to national audiences as an anchor for news segments on ABC News' Good Morning America. She has gone on to host shows for CBS News, Fox News, and CNN. Paula is currently the executive producer and host of On the Case with Paula Zahn, one of Investigation Discovery's longest-running crime series. She is also the host of one of Deb and my favorite shows, New York City Arts on WNET, which is a great showcase that promotes the arts and cultural events in the city. In addition to her Emmys, Paula's insightful and impeccable reporting has won her many prestigious honors, including 6 Gracie Awards, 2 National Headliner Awards, and recognition of her career reportage from the Museum of Television and Radio. She has also been recognized for her work in raising awareness of cancer prevention and treatment by distinguished organizations, including the Albert Einstein College of Medicine, the Beth Israel Medical Center, and the Congressional Family's Action for Cancer Awareness. We're thrilled that she's joining us this afternoon. Welcome, Paula.
Thanks, Rick. I'm really looking forward to our conversation, and I know our audience is as well. I'm very pleased to be taking part in your webinar series. These sessions have been an incredible font of information for viewers across New York City and all over the country. In a time when the news about COVID-19 is changing so rapidly, there are many varied and often contradictory statements being made, and I think we're all finding it difficult to know who and what to believe. And that's why it's so valuable to have a source of information that can be trusted, and Rockefeller University really is that source. For those of you who are new to the Rockefeller community, the university is a scientific powerhouse. 25 Rockefeller scientists have been awarded the Nobel Prize. If Rockefeller were a country, it would rank 4th in the world in the number of Nobel Prizes received in medicine and chemistry. Now that's impressive. I have the good fortune today to be talking with one of Rockefeller's brilliant scientists who you met just a minute ago, Dr. Rick Lifton. He came to Rockefeller in 2016 from Yale, where he chaired the Department of Genetics. His work has led to new therapies for a wide variety of human diseases, including cardiovascular and kidney disease. Rick is a member of the National Academy of Sciences, and he won a 2014 Breakthrough Prize. I look forward to hearing his thoughts on the COVID-19 crisis this afternoon. So, Rick, you have to admit that the statistics are downright startling. The United States has significantly more COVID cases, more COVID deaths than any country in the world, including countries that are far more populated than ours. And now the United States is reporting record new cases. Why are we lagging so far behind other countries in controlling this disease?
The situation with the pandemic in the United States is obviously alarming. It started with a bang in New York City. I think the overall trajectory of the pandemic has reflected a failure of public health measures across the country. There's been failure initially in developing a test and not recognizing that we needed a test desperately at the outset. So the virus had an opportunity to spread in communities, including Seattle and New York City, without anyone really being aware of it before suddenly it exploded like a bomb in the middle of March in New York City. Since that time, New York City and other parts of the Northeast that have been hard hit have been successful in beginning to contain the virus through, I think, very heroic public health measures that have resulted in lockdown of the local community so that people were not going out for several months. And I think there was sufficient alarm in the general population that people took this very seriously and did not waver from not going out unless absolutely necessary to get food or medical care and so forth. So while the Northeast is now on pretty good footing with, for example, in New York, fewer than 1% of all tests taken are positive for the virus, viral RNA itself. We're now seeing surges in case numbers across much of the rest of the country. So as of today, more than 30 states are reporting increases in the number of cases every day. This is accompanied by increasing numbers of people being hospitalized every day. Particularly hard hit is Florida, Texas, and Arizona, where there are truly alarming levels. In just the last month, the number of new cases have increased by a factor of 4 to 6 in these states. This is not the way this should have played out. These states should have been well aware of the potential of a pandemic hitting their areas and should have taken much sterner precautions over the last several months to prevent coming to the stage that we're at now. This is a massive failure of public health. If you look at the United States today, with 50,000 new cases being diagnosed every day, with hospitalizations increasing in many states across the country, in some cases to levels that rival what we saw in New York City at the end of March, we are in a situation that it's hard to believe that a country as well developed as the United States, financially and healthcare, is at today. If you compare our situation, for example, with Europe, we have about 10-fold more cases per day now than the whole of Europe does. This is, you can't put sugar coating on this and recognize this as anything other than a massive failure of public health efforts.
A massive failure and true humiliation for the United States.
This is an embarrassment for what many of us consider to be the greatest country on earth to have failed to control this virus when it was foreseeable. Other countries around the world, countries in Asia were hit without much warning and have succeeded in keeping virus levels low either throughout or have gotten control of them. There have been some failures, to be sure, but by and large, much larger countries that were hit hard in a similar way, hard as we were initially, have done very well in containing the virus. We have not done a good job.
No, it's quite striking when you look at some of the graphs I know you and I both have looked at, where it looks like the story of two different pandemics in Europe and here. It's that striking, isn't it?
Yes, I think that's right. Mark Twain once said, there's nothing learned from the second kick of a mule, and we seem to be intent on learning this lesson over and over again. We could rightly be blamed for not having been prepared for the first wave that hit the Northeast so hard, but we've gotten through that to a certain extent and hope that that continues. But this wave that we're now seeing across the rest of the United States never should have happened after the experience that we had in the Northeast.
I would like to circle back to a couple of reasons you made reference to. You talked about the late development of a COVID test. Where are we now? Because a lot of people are not only questioning the accuracy of the tests that are on the market today, But also we know that we have individual states competing against each other to get supplies of the tests.
The tests that are developed that detect the viral RNA, which is what tells us whether there's an acute infection or not, this test was developed on a platform that was not terribly well suited to the scale that is necessary for handling a pandemic of this magnitude. Most of us who have paid attention to the pandemic and have thought about what scale of testing do we really need to be able to handle it across the country, believe that it would have been great from the outset to have millions of tests per day available. At the outset, we struggled to get numbers up into the 100,000 level, and we currently are at about 500,000 tests per day across the entire country. That's still quite a ways away from what would be ideal for being able to ring fence every infection that occurs and through contact tracing, find everybody who has been infected. You know, if you think about what one of the goals of prevention going forward is, in parts of the Northeast where the positive rate is now so low, on the order of 1% of all tests are positive, when you find a positive test, you really can do contact tracing. And if you do a good job of that, you can break the cycle of transmission of the virus and prevent its spread to new people and thereby ultimately lead, hopefully, to extinction of the virus in that population. When you have thousands of cases every day, as is happening in some parts of the southeast and southwest, that becomes extraordinarily difficult to try to do contact tracing. So all you can do is try to identify every case and tell everybody to stay home. It's very challenging. But there are paths to scaling up testing that are being developed, and I'm optimistic that some new tests are being developed that will be more scalable and enable anyone who wants a test to get a test quickly, either in a laboratory or at home.
But how long is that going to take?
The true at-home testing that's analogous to home pregnancy test, for example, is likely many months away. There are approaches to collecting, rather than having a healthcare professional swab your throat or your nasopharynx to get a sample. There are saliva-based tests that are being developed and rolled out with emergency approval by the FDA that allow people to simply get a test perhaps sent to their home, spit in a cup, return a sample of that saliva back to a laboratory to have the test done remotely. This is being piloted at Rockefeller and a number of other institutions and seems very promising in the immediate term. This is something that can start very soon. But scaling up, we've discussed in an article that Harold Varmus led in The Atlantic earlier this year. We talked about using technologies that are better suited to this kind of testing, next generation DNA sequencing, rather than the current technologies that could handle truly protean numbers of individuals. But linking that whole chain from collection to laboratory to testing to reporting out is still a challenge that we haven't solved.
So developing these more sophisticated tests, being able to get our hands on them, ramping up production are just a couple of issues. But what I'd like to know is if you think the United States has actually developed a testing strategy to bring our numbers under control.
No, we are all operating as one-offs. Every state is doing their own versions of testing. They're largely operating on the same platform, which is this PCR-based platform that is a strategy that is not extremely scalable at the levels that may be necessary. And every state is pretty much on their own to decide how many tests do you want to do, what kind of turnaround can you achieve. It's very unsatisfying that we don't have a national strategy.
In the meantime, Dr. Anthony Fauci is now warning if we don't find a way to break this new spike in increased cases, we could be looking at 100,000 new cases of COVID a day.
Well, so this underscores the need that in the absence of a national strategy, every state needs to take this very seriously. And we can't have anything goes strategies in states, as we've seen in some cases. As you know, some states across the country never really shut down and just thought that we would muscle our way through this. Unfortunately, the virus has other ideas and seems to have gotten the upper hand in a number of states.
You certainly recognize how devastating the economic consequences have been of COVID. And we're now seeing states, as you mentioned, reversing course and re-implementing and reimposing restrictions. What do you think is the right balance?
Well, certainly the need to balance the economics versus the healthcare risks is a critical one. And I would add to that the educational needs of children in this country. I think it will be catastrophic if children can't go to school because of not just the educational knowledge they acquire, but also the socialization that happens as children interact with one another and the rest of the world. So the economic consequences are clearly profound. Current estimates are that GDP this year in the US may be down about 5.8% by some estimates. Compared to what we would have had without the pandemic, maybe $1.6 trillion shaved off our economy. That's an enormous hit. On the other hand, the obvious way to solve that problem is to get control of the virus. And we've had one swing and miss at doing that on a national scale. But I think it's clear that we are going to continue to take a severe economic beating as long as we have parts of the country that have rampant virus as we do now. So I think the path forward obviously has to go through getting control of the virus. And that may require going through these painful iterations again of reducing economic activity because the virus is spreading so rapidly through communities that the impact is going to be even greater if we don't get control of the virus.
So you talked about the dire need for a government strategy in tamping down these numbers. You talked about the challenges of greater production of testing and making these tests more widely and more easily available to the public. But where does personal responsibility come into the equation? Personal responsibility
is obviously at the end of the day essential. I think in places where there has been strong leadership from governors, it's been shown that the population is willing to follow strong leadership. But it has to be a consistent message that is meted out in a way that inspires people to recognize that we are in this together and we can get through this together. But if we all go our own separate way, it's going to end badly for everybody. And I think we're seeing that play out now.
But you'd have to acknowledge the messaging hasn't been all that consistent, has it? From the federal government?
Certainly from the federal government, the messaging has not been consistent. And I think in some states, the messaging has been much more consistent. I think New York has done a good job on the messaging front. And I think the population, which, as you know, is extremely diverse, has been quite unified in following the advice of the governor.
Rick, can we talk about masks for a moment? You have seen, as I have, and folks in our audience, fights break out all over the country, at grocery stores, restaurants, banks, between those who wear masks and those who refuse masks. We've seen federal officials who refuse to wear masks in public. What do you say to Americans who won't wear masks?
The first point is, there is unequivocal evidence now, if there was any doubt before, that wearing masks reduces the spread of the virus. This should not be a political issue. This is a scientific question and a medical question of how do you prevent the spread of virus. We now know from multiple lines of evidence, everybody agrees that wearing a mask reduces the risk of spreading the virus. It reduces the risk of you in catching the virus. It's not perfect in most cases, but it does make a material difference. But very importantly, there are many people who are asymptomatic with infection. They're unaware that they have been infected and they have the ability to spread the virus. Wearing a mask prevents you from spreading the virus to others. Again, it's not perfect, but it makes a very demonstrable difference. So this should not in any way be a political issue. This is a public health issue, and we simply need to eliminate the idea that your politics dictates whether you will wear a mask or not.
Do you view masks as the number one line of defense against COVID?
Well, I think there are several. I think distancing, washing hands, wearing a mask, I think these are the cornerstones of prevention and are the strongest things that we have going.
So contrary to what the World Health Organization and the Centers for Disease Control and Prevention have stated, many scientists believe that the virus sometimes spreads through tiny aerosol particles, not simply through large respiratory droplets. Can you explain that to us?
Yes. So I think that it remains a somewhat controversial issue. In my view, this is not a critical element to the debate, whether the droplets are large or very, very small. We know that there is respiratory spread of the virus. We know that the louder we talk, the louder we sing, the more we are putting into the environment, the farther we project them. And the size of them, I think, is less critical than that we can prevent the spread substantially by wearing a mask.
Can the virus spread through an air conditioning system in someone's home or someone's workplace?
Most ventilation systems in industrial settings, such as a high-rise in New York, have sophisticated ventilation systems that prevent the spread of the virus. As you know, there have been many people in essence, in lockdown in New York City for the last several months. And there were no outbreaks that I am aware of that were spread by the ventilation systems in the high rises in New York City. So I don't think that that has been a general mode of spread. Where I do think there is concern is if you are in a room that is poorly ventilated with a significant number of other people who, some of whom may be infected, I think these indoor environments are environments in which spread of the virus can occur. And this is one of the concerns about reopening small businesses where there's, for example, restaurants where there's indoor seating.
While we're on the issue of transmission, I wondered if you could clear up some of the confusion surrounding reports of late. Let's break this down to surfaces. How active is the virus on cardboard?
I think the collective evidence suggests not very much. I think initially many of us thought, well, if we've got a package delivered to the house, we should disinfect the cardboard. I think most surfaces, the virus does not survive very well on these surfaces for very long. I think setting a package that comes into the house aside for a day before you open it would be a reasonably prudent thing to do, likely unnecessary. Another approach, of course, is simply to open the box, take everything out of it, put the box away, and then wash your hands. I think that also is a very good way of dealing with it that carries quite low risk. I think in general, the surfaces that one would worry about are harder, shinier surfaces like door handles that everybody might be using, that frequently cleaning those surfaces is a good idea. We don't know the extent to which spread occurs from these kinds of surfaces as opposed to through aerosolization. But I think these are prudent prudent measures to take.
How would you characterize where science is in its overall understanding, not only the transmission of this disease, but the impact of the disease on one's health?
I think we are still in the mode of gaining knowledge about how the virus is transmitted. I think, for example, the protests that have occurred over the last month, one might have imagined that the absence of social distancing, the somewhat varied wearing of masks in demonstrations, it seemed likely that there would be a surge in cases resulting from this exposure. But the fact that it was outdoors seems to have been a strongly mitigating factor that I think has suggested that outdoor exposure may be less likely to be a source of infection than we might have suspected. Further epidemiologic evidence has suggested that many infections tend to occur in environments where we are encountering family members and coworkers at our place of work, and less likely out on the street, for example. There's a lot of concern about public transportation. Many conductors on the subway and bus drivers have been infected. But again, this gets back to the time by exposure factor. These people are in the environment for very long periods of time. A number of studies coming out of Paris, out of Seoul, out of Tokyo, and Hong Kong have quite substantial, very large public transportation efforts and have not found significant risk of ridership in those environments. These are environments where people are typically wearing masks, and hand washing after riding on the subway is encouraged. These seem like plausible ideas. We don't know how much risk there is in these kinds of environments compared to others.
Rick, there is a wide range of outcome of COVID-19. Many people have mild symptoms or no symptoms at all. Others develop pneumonia. Many die. What accounts for this broad range in disease outcome?
Paula, this is one of the biggest mysteries about this virus. If you compare this to influenza or to the previous SARS epidemic from a number of years ago, the number of asymptomatic people who, even in retrospect, after they've been diagnosed as having had the virus, say, no, I didn't have a fever, I didn't have a cough, I didn't have body aches, I didn't feel fatigued, I had absolutely no idea that I was infected, is quite striking. And the course of this disease is very different from many. The typical course of a patient who ends up with severe disease is they start off, and after 4 or 5 days, they seem to feel like, well, this is just like any other flu. I may be getting a little bit better. And then day 5 to day 9, everything goes downhill and develop shortness of breath, chest tightness, and signs of pneumonia as well. And in that period, that's when people tend to get hospitalized. And then, as you said, many go on to need respiratory support with intubation, and many go on to die. This is a very unusual pattern, and we don't understand the variability well. We know that there are some risk factors, such as age, some comorbidities like pre-existing cardiovascular disease, diabetes, obesity seems to be an independent risk factor for progression. But we suspect that there are factors that we don't understand, either in the particular nature of the immune response to the virus or host genetics, that particular genetic variation in the person who gets the disease that may predispose to severe outcome. But we're pretty early in trying to understand what those biological factors may be.
There have been a number of reports lately that would suggest maybe blood type plays a role in one's outcome if they get COVID. What do
Yes,
you?
so this is a very, I think, interesting observation that has recently gained support from a well-powered, sophisticated so-called genome-wide association study that has looked at people with severe disease, has found that individuals who have blood type O seem to be relatively protected from developing severe disease, and people with blood type A seem to be at higher risk, about a twofold increase in risk of developing severe disease compared to people, for example, with blood type O. The suspicion is that it is not the red blood cells themselves that are determining the outcome, but the enzymes that determine the blood type. So particular proteins on red blood cells get a modification called glycosylation. And the enzymes that mediate that glycosylation also modify other proteins, and in particular, the spike protein of the SARS-CoV-2 virus that causes COVID-19 is a highly glycosylated protein. And so there is speculation that this observation of the association with blood type may relate to how glycosylated this spike protein is, and whether your immune system recognizes that as foreign or native, that is a particular driver. And this is an unexpected observation, although there's precedent for it with other viruses.
Gender is something that's being widely discussed today. Is it true that more men are dying from COVID than women?
It depends on the age. So there seems to be an age limit to this effect. If you look at younger populations, it is undoubtedly true that more men than women die from COVID-19. And then as you get to age 70, roughly age 70 and above, that difference starts to shrink, so that both men and women at older ages have more similar outcomes. The biological difference in early ages is entirely unclear. But it goes along with some things that we have known in medicine for a long time. For example, we know that autoimmunity tends to be, autoimmune diseases such as lupus and diseases like this are more common in women than in men, suggesting that something about women's immune system may be more active in certain circumstances than a man's immune system is. So you can imagine that while that might predispose women to have more frequent autoimmune disease, it might predispose men to be more susceptible to viral infection and to bad outcomes. Now, we don't really know the reason for this. Is this a difference in our hormonal milieu? Is it a difference that men have one copy of the X chromosome, where there are a lot of genes that may play a role in regulating the immune response, whereas women have 2 doses of those same genes, and that may play a difference? We really don't know the explanation for these differences, except they seem to be quite large at younger ages.
Can we talk about children for a moment? Because I think a lot of people find this very confusing. That you have many children who are exposed to COVID-19 that remain free of symptoms. How do you explain that?
Yeah, so it is fascinating. This is, I think, fascinating biology that newborn children in particular seem to have potentially be less frequently infected, although we don't have strong data on that. But also have less frequent onset of symptoms. This is almost the opposite of influenza. When we think about influenza or more typical flu, young children and older adults are the group that gets severely affected and die. This COVID-19 is quite different. It is extremely uncommon for very young children to get really ill and die from this disease. In fact, most of the deaths that are coming in children come from this very unusual multi-system disorder that seems to be a consequence of the immune response to the virus, not from rampant infection from the virus itself. And this disease was recognized in New York City in just the last month or two, and is a very unusual situation, resembles a disease that we've seen before called Kawasaki syndrome, that is recognized to be a consequence of an abnormal activation of the immune system that is causing significant disease outcomes. So the reason children seem to have less manifestation of infection, there's been a lot of speculation, not a huge amount of data. There's some data that the receptor for the virus on the epithelial cells in the body and other tissues is less well expressed early in life than it is upon maturation. This is the ACE2 protein, and that's one possible explanation. But the biological difference is quite striking in the fraction of young children who become symptomatic.
So how concerned are you about the ramifications of children eventually getting back into classrooms in America?
Yeah, so this is, I think, a huge question that I don't think we have begun tackling appropriately at this point. I think the challenge in returning to school in September is going to be several-fold. First, how do you prevent rampant infection from spreading through school systems where, particularly at the youngest ages, that children are not likely to be terribly effective in practicing social distancing all the time, may not be capable of wearing masks all the time. So you're setting up an environment where a lot of infections could occur, putting the teachers and people in the schools at risk, putting families that the children are going to go home to at risk. These are serious questions that persist as we go to older ages as well, including colleges, where you have young adults who are in dormitory situations where social distancing is not so easy, and I think it's a big quandary for us to tackle. Again, it would be ideal if we had point of care testing, that you could test every student going into school twice a week. We know the incubation period for the virus tends to be 2 to 5 days to the median, and out to 14 days. If you could test everybody twice a week and send everybody home who has a positive test and allow people to go to school if they're free of infection, that would go a long way toward preventing spread both through the school system and from children carrying infection home. I have a lot of concern about either of the options that we're confronting right now, which is try to have children learn from home, which has tremendous impact on the economy, the ability of parents to go to work when the children are young, or the spread of infection, which is going to get us back in the box that we've been trying to get out of.
Let's move on to the issue of the race to get a vaccine. We know that there are many candidate vaccines for COVID-19. I understand there's a strategy to ramp up production of the vaccines before their efficacy has even been shown. Is that a smart way to go about this?
I think it's the smartest thing the federal government has committed to in this epidemic, in fact. Again, if you think about what the cost of doing that is, several $billion, $10 billion, a large number, but you compare that to the impact that the virus is having on our economy, $1.6 trillion perhaps per year. That's a bargain in my view. So if you can prevent a year's worth of economic downturn from occurring by getting a vaccine out sooner, if you wait until you know, here's the one that's going to work, you're not going to be able to scale up delivery of that for, you'll delay that by at least 6 months, if not a year or more. So I think when the pandemic began, there were major questions as to the likelihood that we would be able to get an effective immune response to the virus, and that would be likely to prevent people from getting infected for at least a reasonable period of time. I think it's clear now that the responses to the vaccines that are in the clinic now seem to be at least pretty good. And pretty good would be enough to reduce the incidence of infection, I think is highly likely. Boosters, as we commonly do with vaccines, you come back and get a second shot, may get quite high levels of antibodies. So I think that question looks reasonably favorable. It also looks highly favorable that the antibodies that get made do not seem to cause problems themselves, as sometimes happens with vaccines. We now know that both from the vaccine trials that are ongoing now. We also know it from convalescent plasma, where you take plasma from people who have recovered and give it to somebody who is ill with COVID-19. There have not been complications from the antibodies that have been transferred to other people. So these things give confidence that there is a path forward. We know that you can get an immune response to the vaccines. We know that it doesn't seem that that needs to be toxic. We don't know in the case of the individual vaccines whether there will be toxicities. But I'm quite optimistic that there's a path to having a vaccine now. And that's quite different from where we were 6 months ago. So I think that's all positive, and it just raises the question of how fast can we get a vaccine through safety and efficacy trials and then be ready to begin delivering it broadly to the population.
I love your sense of optimism about this, and I hope it is borne out by the facts, but do you really believe it's realistic that we will have an effective vaccine by the beginning of next year?
So I think it's plausible. It's plausible that we will have the results of phase 3 trials that show that it is efficacious. Safety, we'll have certain levels of indication. Many of the trials are enrolling on the order of 30,000 people, 15,000 typically getting randomized to the vaccine, 15 getting placebo. That'll be a substantial amount of information about safety as well, which is obviously critical. The key element is how fast can you scale up production and delivery. And I think the most optimistic views are you could get tens of millions of doses prepared, maybe 100 million with great effort by the end of the year. That obviously is not going to cover the country, much less the entire world. That's going to be a much longer lift. But I think the opportunity to have a vaccine perhaps by the beginning of 2021 that can start to be delivered to people at particularly high risk, I think is plausible.
Who will decide who gets the vaccine first?
People who are most likely to benefit from it. People who are highly exposed due to their employment would be obvious initial candidates. People who are at high risk of adverse events, as we've talked about some of the risk factors.
What does it mean to you that Dr. Anthony Fauci said he is willing to accept a vaccine that's 70 to 75% effective, given the fact that a growing number of Americans are saying they're going to refuse to take the vaccine once it's available?
Those are two different issues. I think it would be a huge win if you had a vaccine that was only 70% effective. There's an awful lot of disease prevention that could be achieved with the vaccine that is only 70% effective. You may not get to the point of herd immunity if only half the population takes a vaccine that is only 70% effective. But the people who are protected, I'm sure, would be grateful to be spared getting this disease.
I wanted to talk about an institution that's very near and dear to your heart, and that is Rockefeller University. And it is really impressive that when the pandemic hit, that 20 Rockefeller laboratories quickly directed their research towards COVID-19. Can you give us an idea of a few of the studies that are going on and in particular, maybe related to potential treatments?
On the potential treatment side, we have several efforts. One of them was to try to get convalescent plasma up and running quickly. And we partnered with the New York Blood Center, which is just up the street from Rockefeller and is a very large provider of blood products in the city. To begin developing and expanding the capability to do convalescent plasma, taking plasma from people who have recovered from COVID-19 and provide it to people who are infected and particularly have severe infections. One of the challenges at the outset was we didn't know which plasmas were likely to be effective and which ones weren't. And so Paul Benash at Rockefeller developed a rapid assay for screening the plasma for those which have the highest titers of so-called neutralizing antibodies that can prevent the virus from infecting others, from infecting cells. And that has led to recognition of scalable tests that can be very useful surrogates to identify which plasmas are the most likely to be efficacious. And this is helping to fuel these convalescent plasma trials that are ongoing now. A companion to this is work by Michelle Nussenzweig at Rockefeller, along with Paul and Charlie Rice, a renowned virologist at Rockefeller, who have been identifying among all of the antibodies that people infected with the SARS-CoV-2 virus are making, identifying which antibodies are the most potently able to neutralize the virus and keep it from infecting cells. And so this was planned from the start of the pandemic in New York. You may recall that there was a big outbreak in Westchester, and we began by making contact with many people in Westchester who had been infected, and these were the first infected people in New York, and recruited them to come to the Rockefeller Hospital after they recovered to give blood, and began screening those blood samples, and ultimately out of 1,500 volunteers, studied 160 people from this group of newly recovered individuals, and identified antibodies that in fact were highly potent and capable of preventing the virus from infecting cells. And so this was published just 2 weeks ago in the journal Nature, and is a major development. In particular, Michelle has identified 2 different antibodies that bind to different parts of the spike protein that is used to get into cells. And these 2 in combination have terrific potential to be used clinically, both to treat people with severe infection who aren't doing well, but also as prophylaxis to prevent people from getting infected. Well, these antibodies can be given for example, to elderly people in nursing home environments where they are clearly at higher risk than the general population of getting infected, to try to prevent them from becoming infected. So this is a kind of project that we just take great pride in being able to execute, from idea all the way through to demonstration of biology. And now these antibodies are being scaled up for clinical trials that we hope will begin this fall. And these need not be long-term studies that could turn into therapeutics rather quickly. Another example on the therapeutic side is We don't have very many useful treatments in terms of drugs that prevent progression of disease or can stop disease in its tracks. And we have a number of projects ongoing that target proteins that are essential for the viral life cycle that are in early stage clinical development. And these will take a longer period of time to work out. So Jean-Laurent Casanova at Rockefeller is the world's leading authority on genetic susceptibilities to viral infection. And so when this pandemic started, he began collecting patients from all over the world with severe outcomes of COVID-19 and has been sequencing their genomes, looking for genes that are mutated more frequently than you would expect by chance. And he now has completed the sequencing of more than 500 of these individuals. And there are tantalizing clues to recurrent pathways that appear to be mutated more often than they ought to be. And these have the potential to suggest specific avenues to therapy that may be relevant, not just for these people, but for many other people with severe infection. So these are the kinds of efforts that are underway at Rockefeller, and the 20 labs all have extremely different, very creative ideas of ways that they can uncover new biology that may be highly relevant to impacting this pandemic, and we're so proud of these efforts.
Well, I truly salute the very important and hard work you're doing at Rockefeller. I want to move on now to some questions that have come in from our audience. And the first one has to do with what happens when the flu season collides with what is expected to be a second surge of COVID this fall.
It's fair to say at the outset that the virus will make up its own mind, if you will, as to what happens this fall. We can make plans, but we really have little idea. As you'll recall, there had been a lot of speculation that, well, when the warmer weather comes, the SARS-CoV-2 virus won't tolerate that and it'll all go away. That hasn't, unfortunately, turned out to be true. So I would just say we really don't know what is going to happen this fall, except that the virus is still around, and it seems likely that we will have a second wave, and that will commingle with influenza. So there are good efforts underway in industry to develop joint tests. So when people come in with symptoms compatible with influenza or the SARS-CoV-2 virus, you can test for both in the same assay. And that will help sort out who's got regular influenza that can be expected to go home with a relatively mild course, and those who have COVID-19 that may have a different course and hopefully treatment by that time. We don't know whether the two will commingle in the sense of the same person being infected by both. We have host pathways, the interferon pathway that works to prevent another infection from occurring when you've got one infection going already, but we don't know how effective that will be in the setting of these particular viruses.
On to the second question, Rick, from one of our audience participants. Can someone who has recovered from the virus still transmit it? And can you get the virus a second time?
The evidence to date strongly suggests that once you recover from the virus, you are not at all likely to be capable of transmitting the virus to others. The best studies that I have seen are studies that have sampled for the viral RNA tests, but have also sampled to see whether you can culture the virus from the specimen from patients on consecutive days after they start with symptoms and are diagnosed. And the results have shown that once the immune system kicks in and starts making antibodies to the virus, that you continue to make viral RNA and you can see RNA, so you can get a positive RNA test. but you can't culture the virus anymore once the immune system kicks in. This strongly suggests that it is extremely unlikely that people are going to be able to transmit the virus once they have recovered. And there are not any good data that suggests anything contrary to that. So I think it is very safe to assume that once people have recovered, that they are no longer at all likely to be infectious to others. The companion question of, if you've recovered, can you be infected again, is an ongoing question that we really don't have clarity to. It is clear that some people continue to make viral RNA for alarmingly long periods after they have recovered, feel completely normal, or back to their usual activities. There are reports out to about 60 days after recovery that if you take a swab, you can still find viral RNA. That's not the same as having virus. We don't think that these people are still infectious. But how long the immune system that helped you recover from the viral infection is likely to continue to keep protecting from infection is an open question. And there is reason to suspect that immunity from this virus will not be as long lasting, for example, as recovery from measles would be, or vaccination from measles. Other coronaviruses tend to, of which cause, in many cases, common colds, for example. We keep immunity to those viruses for perhaps 1 to 3 years and then can get reinfected. That may be the case for this virus. We don't know the answer to that. Among the things that may be relevant to that are that it appears that many people who recover don't have a huge amount of antibody against the virus, even after only 3 or 4 weeks after recovery. However, the responses to some of the vaccines that are being developed, it appears that they can generate a much stronger response than you get from a natural infection in many cases. So we won't know whether natural infection confers long-lasting response, nor until we get more experience whether vaccination, assuming that some of these are successful and make it to market, whether those will confer long-lasting infection immunity, or whether you need to get revaccinated every once in a while.
On to the next question. There have been reports of recent studies that show a mutation in the genetic structure of the virus appearing frequently in patients in Europe and the United States that may make the virus spread more easily. As a geneticist, what are your thoughts on this subject?
The observation that we know is true is that this mutation was not prevalent in China when the virus first appeared, and is prevalent in Europe and the United States now. And so there are two plausible explanations for that. One is that this virus that just has this single amino acid substitution in the spike protein, one of the building blocks of the spike protein, that mutation gives a replicative advantage, makes it easier to infect cells, gives more virus, and it's taken over the population by selection, that it's more fit to replicate than its predecessor. An alternative explanation is that this mutation just happened to be the first one that appeared in Europe and took over the population before the other one showed up and was outcompeted just by having such a big head start. This would be called the founder effect, or in genetics, Muller's ratchet, that something became prevalent not because it was any better, but it just happened to establish itself first. We don't really know at this point which of those two alternatives is likely to be correct. There are some experiments that suggest that the mutation makes the spike protein more stable than its predecessor. Counter to that, a number of virologists have shown that that mutation does not appear spontaneously when you propagate virus in culture, as you might expect if it actually had a selective advantage. So I would say the data right now are equivocal in either and not clear cut in either direction, but I would suspect in a relatively short period of time we'll get better insight into that.
I have 3 quick questions for you left. What percentage of the US population must be exposed before some level of herd immunity is achieved?
So herd immunity is that level of infection at which new infection introduced into the population can't be sustained because there aren't enough people who are still susceptible who can be infected. So you can see intuitively that the level of infection that you need to have in the population before herd immunity occurs will depend on how infectious the virus itself is. So for example, for measles, which is extremely infectious, to get herd immunity, you need to be at least 90, if not 95% of the population has to be immune to infection. The SARS-CoV-2 virus does not appear to be that infectious, and as a consequence, most people have estimated that you could get to herd immunity at about 70% of the population having been infected. Importantly, herd immunity does not mean that nobody will ever get infected again, because there's still, in that case, 30% of the population that hasn't been infected that could be infected. It just means that the virus will not be propagating for a long period of time because it can't find enough people to then pass the virus on to keep the chain of transmission going. So So importantly, 70% is a limit that we'll need to get to. We're nowhere close to that in the United States in any population yet. New York City, with the serologic tests, testing for antibodies, it appears that in New York City, for example, about 20% overall of the population has been infected with the virus. It's a much larger number than the people who we have had symptoms that have led to them getting diagnosed with an RNA test. But still, that number is nowhere close to herd immunity. So we have a long way to go to get to herd immunity, either with natural infection or with a vaccine.
Have we really made any progress in the treatment of COVID-19 in the last couple of months?
I think that's an important question, and it's important to say that the answer is resoundingly yes. We have much better ability to keep people alive. We recognize much better that people need supplemental oxygen earlier than they may recognize. It's been striking how many people are not aware that their oxygen levels are dropping. And so we now recognize this as a risk earlier, get people on supplemental oxygen earlier. And we now have a couple of therapies that are proven to be efficacious in preventing severe disease, progression of severe disease, and in helping with recovery. So this drug remdesivir has been shown to reduce the length of time to improvement by a significant degree. We don't have data yet that proves that it prevents death compared to people who don't get this drug. But we do have data that you can significantly prevent death from this virus with steroid treatment. So a randomized controlled trial just reported out of the United Kingdom a few weeks ago showed that dexamethasone, which is a potent steroid that's an anti-inflammatory, it's about 10 times, actually it's more than that, it's about 40 times more potent than cortisol, which is your natural steroid that prevents inflammation. That dexamethasone can reduce the risk of progression and death from the virus by about 35%. Which is a very substantial advance. And there are other drugs that are in clinical trials now that have similar potential to impact the virus. And one, has to both be optimistic about the potential for impact, but also hard-nosed that we need to get real data. I don't think we have enough drugs that are being developed that are well tailored to the virus itself. We have drugs like remdesivir that were repurposed because they worked on other viruses that have some efficacy. I think we can do a lot better. And the big question is whether we get a vaccine that is so good that we don't need any other treatment. I would argue today that we don't know what the future is with vaccines, and I think we need to keep pressing forward with every potential avenue to mitigate the impact of the virus until we have things that help everybody.
In closing, Rick, I understand more than ever before scientists are sharing data, they're collaborating, working together to find a cure for COVID-19. Pharma and biotech companies are also rising to the occasion. Can you comment on this cultural change? And do you really expect this cooperation to continue post-pandemic?
Well, it certainly has galvanized the research community in a way that we've rarely seen before, particularly at the scale that this has happened, that goes across academic centers all the way through to pharma, that everyone recognizes that this is of proportions that we have never seen in any of our lifetimes. Certainly nothing like it since the 1918 influenza pandemic. And as a consequence, people are sharing data, are collaborating in ways that don't come naturally. I've seen pharmaceutical companies sharing resources in ways that I've never seen before. Academic laboratories are working not just between labs, but between institutions across international boundaries as well. So I think all of this is very positive. It's not an entirely novel way of working, but it's happening at a scale that is pretty well unprecedented, and one can hope that this continues in the future.
We all hope for that. Well, Rick, it has been an absolute pleasure to be able to talk with you. I feel like I've been back to school with you today. Thank you for cutting through so much of the contradictory information out there. And again, I think I speak for our audience when I express our deep gratitude for everything Rockefeller University is doing to confront COVID. Best of luck to you and everyone in the trenches there.
Well, thank you so much, Paula. We can't thank you enough for taking the time to be with us today. It was a wonderful experience for all of us involved, particularly me. It was a thrill to share the afternoon with you. And I want to thank you for all of your time and effort and all of your study ahead of time. I've rarely been questioned with such close attention to the details, and I appreciate it very much. It was in my view, a huge public service to have you involved in our program.
Well, Rick, I truly appreciate that. Your generosity is quite meaningful to me.
And I want to thank everyone in the audience today for your participation. We still obviously have a long road ahead of us. And I just want to mention that philanthropic support continues to be vital to our progress. Please see the concluding slide for more information about how you can contribute and help us combat the COVID-19 pandemic. So until we meet again, I hope you'll continue to visit our website for other COVID-19 research news and for recordings of our past sessions. Please stay tuned for announcements of upcoming programs. We might have aspired to be done with this by now, but it looks like there's still a road ahead. We'll be there for you, and all of us here at Rockefeller hope that you will stay safe and healthy. Thank you very much for participating this afternoon. Good evening.